Hi, everybody. Welcome. This is Dr. Isabella Wentz, your thyroid pharmacist. Today I'm visiting with my dear friend Carter Black, registered pharmacist. He is a graduate of the University of Illinois College of Pharmacy with undergraduate work at the University of Illinois at Champaign-Urbana. He is a preceptor for pharmacy students and is a consultant by doctor referral for women and men's health, hormone, and thyroid issues. Carter Black has 5 years experience as a professor of pharmacology at Pacific College of Oriental Medicine. Mr. Black also has extensive training through the Institute of Functional Medicine, Hakim Hashimoto's, and the Hashimoto's Institute. He has over 40 years experience working with compounded medications and bioidentical hormones, and he's my go-to resource for compounded medications. He's been really helping me a lot since 2011 when I moved back to Chicago and started visiting his compounding pharmacy. He's one of the first people that told me to look into my adrenals as a potential root cause and a potential trigger. And so, Carter, thank you so much for being here, and thank you for the work that you do to help people, especially me. You've helped me so much in my health journey.
Well, thank you.
So I really wanted to pick your brain. This has been long overdue because you're really my go-to expert on women's hormones, and you are just so passionate about women's health and so knowledgeable. Can you tell me how you first became interested in women's hormones?
Well, I think working in a compounding pharmacy, I've always felt that women are marginalized in their health. And as a matter of fact, it's well documented that, and I'll get to this later, that women's health and heart health, which is a major health factor in women, is they're not treated the same as men. They don't get the same attention. I've known that forever. And then what happened was I was in the compounding pharmacy, and someone needed to be the information source for women because a major market was women's hormones. And this was back in 1998 when I started. Mm-hmm. The internet wasn't what it was then, and there was no real good information except maybe word of mouth, and some of it was wrong, and there was a lot of books. So I was the pharmacist that would answer the questions for the women, and we had a major practice down the street from us, and so we did a lot of women's hormones, and I just enjoyed it. I started the compounding practice with another pharmacist, basically from zero. And we just decided that this would be a better way to go. And compounding, to define it, is really making custom medication to a patient's need. And sometimes commercial medicines can't fill the requirement. There's a lot of your thyroid patients that need gluten-free or corn-free or dye-free medicines. And this is one of the first things we did way back, 20 years ago, because people were discovering that even common medicines were giving them a big problem. So they would come to us when we make dye-free medicine. And then I spent a lot of my time trying to master the subject. And at that time, you had to read books. You had to go to the seminars. There weren't webinars, and I talked to a lot of colleagues too. So it was. The more interest you have in something, the more people come to you, and the more experience you got.
Yeah, and one of the things I was really struggling with my adrenals. We know that adrenals and thyroid health are oftentimes connected, and I was getting compounded thyroid medications from the pharmacy where you were working, and they were helping, but at the same time I just hit a plateau, and you were the first one that let me know that this could be an adrenal issue. And you're one of those people that I've always trusted because you really care about the patient and you really care about the outcomes, and you're not somebody that's just trying to pull a fast one or trying to just tell people things because you have a product to sell. You've never been that person, and I've just seen you interact with patients, and I really, really appreciate it. Women, typically, we have a harder time getting the care that we need because we're oftentimes labeled as hypochondriacs, and a lot of times we're told that everything's in our head, and a lot of times their problems that women are experiencing are just not validated by others. And I know you've helped so many women just by your kindness and your knowledge, and just sitting down and talking with them one-on-one about their hormones and about their health, and just giving them a few tools, getting them started on the right path.
Well, it's, and it hit me very hard when I was working on women's health, that there were so many things that I could have done. My mother passed away of a heart attack when I was 21. And I look back at that, and I knew kind of what the things were going on, but I had no knowledge. And I would never let things happen the way they did. The lack of care, the lack of testing, the lack of medication. And that was my another motivation. And the way I got drawn into thyroid and adrenals was because I could not get my women stabilized on just hormones. So it had to be something else. So I went into the adrenals, and that was good. But then I found out it has to be something else. So yes, it was the thyroid. And you have really increased my knowledge of that. I mean, I don't think I've mastered it, but at least I have a better appreciation of what can be done and why I'm not getting the control I want.
Mm-hmm. Yeah, and it's really important to note, because a lot of times the various hormones, they interact with one another. So it's not just estrogen that lives by itself in a vacuum, and it's not just thyroid hormone that lives by itself in a vacuum, and it's not just the adrenals. So a lot of times we've got a whole hormone soup, a whole hormone symphony, and we want to make sure that we're looking at all the aspects of the clinical picture with the patient. And so a lot of times we'll find sometimes stabilizing the thyroid will help to stabilize the female hormones.
Right.
Sometimes stabilizing the adrenals will help to stabilize the female hormones, but not in all cases. So when we have a person who maybe has their thyroid dialed in and their adrenals dialed in, sometimes they still may have hormonal imbalances. And that's where I think the art and science of female hormone balancing really comes in. And it's just, such a controversial topic right now, because back in the day we were giving every postmenopausal woman hormone replacement therapy. And then there was this big study that showed that it actually had some adverse consequences. And now we're kind of coming back into the realm of things, and we're thinking about, okay, well, were we completely off our rocker to just deny women hormone replacement therapy? Because now there's been shown that maybe the studies didn't have everything dialed in, and maybe there were some other kind of confounding variables. And in some cases, the hormonal therapy may actually be safe and effective. So where do bioidentical hormones come into the picture? And can you kind of talk about this whole hormone controversy that we
right
gone through the last?
Obviously, I went through that whole thing. The big study was 202, and probably before then, in the early 80s, everyone gave unopposed estrogen, and they so there was a big study there, and there were quite a few uterine cancers. So that was changed in the early 80s, so that you didn't just give estrogen, you gave, and what ended out to be the wrong thing to do is they gave progestin, which caused less endometrial cancer or uterine cancer. But now, fast forward, we found out that the estrogen, or the progestin, not real progesterone, was causing the problems with the heart that 2002 Women's Health Institute, WHI, program caused. So, and that's the push for bioidenticals. And it's not necessarily the estrogen that was the problem with that. It was the false progesterone or progestin. So people talk about progestins or commercial progestins and progesterone in the same sentence, and they really can't. The progestin acts more like a testosterone than real progesterone, and it doesn't counter the estrogen like it should. It has the false progesterone has a increase of heart attacks because it affects the cholesterol, and so there was the HERS study that showed that even any estrogen you give with a real progesterone was superior than the product that they used in the Women's Health Institute. So bioidenticals, really what the term bioidentical, if you want to define it, is body natural. I mean, what the body would produce. And that's what bioidentical to me means. And there's probably other definitions. And then there's this term floating around called natural. And natural is interesting because herbs are natural, and you can manage hormone problems with herbs at times. I taught at traditional Chinese medicine college, and they were adept at using acupuncture and herbs for menopause symptoms, but even they would admit that sometimes you just need the real hormones. So we had a very good relationship, the students and the professors and I, and we taught each other. You know, the thing that's normally used in commercially is Premarin, which is Premarin is from horses, and it's natural, but it's really not bioidentical to the woman. So, you know, there's some problems there, but the biggest problem really is with the false progesterone. And you know, if you can, in the hands of a good practitioner, bioidentical hormone therapy doesn't really cause that many problems. I was talking to my colleagues today at the office. They've been in OB-GYN practice for 25 years, and they really haven't seen any problems with hormone therapy in all their years. And I said, how funny. And I haven't really. You know, I prefer, when we do bioidentical hormones, I prefer topical administration rather than the orals that are commercially available. And there is a commercially available patch which has a bioidentical hormone, and then I use a bioidentical progesterone. And the thing about it is when you do topical hormones, they go into the system, go to the target organ, and then are metabolized. So they have lower doses, and their risks of their metabolites are much lower. So that's why I'm a proponent of topical hormone therapy, except for progesterone. Oral progesterone, real oral progesterone, has metabolites that the body recognizes and uses, and they're not foreign to the body. And I use probably my most successful therapy anytime, any place was oral progesterone for sleeping. It's just wonderful, and that's one of the big problems with menopause is sleeping.
Let's back up here for a minute. You just shared so much fabulous information. So for estrogen, you prefer topical products, so compounded topical products, or prescription ones that are already available commercially?
Yeah, there are bioidentical, commercially prepared topical medicines, and one of them is Vivel Dot. I've used that forever. They have a lot of strengths, and you can even cut them. All the hormone is in the adhesive. And then there's quite a number of gels that are commercially available. Estradiol, bioidentical. And I love those.
Mm-hmm. That's really helpful. And then for progesterone, is this a compounded medication?
Yeah, usually we have, so there's plenty of commercial estrogens, but there's only one bioidentical progesterone that I would trust, and it's prometrium. And there are problems with prometrium. It's in peanut oil. People can get allergies to peanut oil. And it dissolves into the body so quickly that sometimes about 30% of my patients will get dizziness. And so I have to use a compounded progesterone, a time release, which is excellent. And then you get a blood level for about 8 to 12 hours, and you don't get the dizziness that the commercial product gives.
That's really helpful. Now, are there any kind of patients where you wouldn't use, I guess, any hormones whatsoever, like maybe somebody with like a breast cancer that was estrogen, that was fueled by estrogen, or anything else like that you can think of?
Yeah, there's several categories. First of all, I've had a few smokers as patients, and they are fast metabolizers, so I've had to have an incredible amount of estrogens in them. Never felt comfortable, and as a matter of fact, that was my only breast cancer in my practice ever, from a smoker. So I don't like to use estrogens in smokers. Also, breast cancer, that is a very hard place to be, because there's quite a number of hot flashes, vaginal dryness, and women are even afraid to put estrogen vaginally, even if it's not absorbed. So there's a number of products that you can use. We actually use DHEA vaginally. Testosterone vaginally works very well. Progesterone works vaginally fairly well. Or if you use a bioidentical called estriol. Estriol is huge. It's made by the placenta during when you're pregnant. Huge amounts of estriol, and it's a non-proliferative. So if you're carrying a boy, you're not going to you're not going to feminize him, but you're still going to get the estrogen effects. So estriol can be used carefully in breast cancer patients. Rebecca Glazer, who I went to a seminar about 20 years ago, and she taught me topical application of hormones to the vagina in smaller doses that you could still achieve hot flash control, and you could get rid of vaginal dryness, which is one of the major problems. And you could keep it at a low dose, so that even lower dose than what I've used, to not absorb into the system. So that's one case. Factor V Leiden patients, where you have risk of clotting, and you understand those patients, I know. So those are anyone with a DVT.
Deep vein thrombosis.
Right. So gallbladder problems, obviously, that's a risk. So there's what we call in the biz rule outs. In other words, we rule out those patients. But that's the challenge. Then that really challenges me. All right, I can't just do the regular thing. Now I have to come up with something tricky to help these symptoms, and so I don't mind that. And the women that can't take the normal therapy, estrogen, progesterone, maybe even testosterone, they're very pleased when you do conquer their symptoms. And some of them are really horrible. Another use, again, Rebecca Glazer uses testosterone in breast cancer patients. She's a breast cancer surgeon in Ohio and has a very famous practice and nationally known.
And so a couple of questions I had for you is, one, why the gallbladder? So how can gallbladder issues, because I know someone with Hashimoto's may have gallbladder issues, and they're more common in Hashimoto's than they are in the general population. So why would that be a contraindication for using female hormones?
You'll notice that as a rule out on oral contraceptives, and it tends to form gallstones. So it's just one of the boxes you check off.
We don't want to increase the risk of gallstones, so that's why we wouldn't want to use hormones.
Basically, I think it causes spasms of the. I'd have to check. I just don't. It's just a question I always ask: have you ever had gallbladder problems? Have you ever had gallstones? And then, oh, okay. I mean, it's just something that you have to watch. Mm-hmm. It's not an absolute rule out like breast cancer. Mm-hmm. Or to me, smoking. If a woman comes to me and they're smoking now, I would not want to do hormone therapy unless they would, quit. So.
And I totally agree with you on the smoking and the breast cancer. Now, for those patients, when they still continue to have symptoms, what's kind of like your backup plan for them? You said you have some secret tricks up your sleeve that you sometimes will figure out how to address those symptoms.
Well, I mean, as you taught, I mean, by the way, I've had classes on every kind of adrenal fatigue or adrenal management. I mean, I probably have seen every program on adrenal fatigue, and your program is the cleanest, neatest, most simple. You really have a nice way, and in your book too, of streamlining things and getting down to the nuggets, the important things. So I use your adrenal program now.
Thank you. Appreciate that. And so did you find with DHEA and pregnenolone, would you consider those bioidentical? Would you put them in that category?
Oh, yeah, absolutely. And pregnenolone turns into progesterone pretty directly. So if we have a patient under adrenal fatigue, we try to balance the pregnenolone with the DHEA. And I do have to go to commercial things, like if I have a breast cancer patient, I mean, then might be forced to use the all the things that like the antidepressants or gabapentin, or some of the things such as the SERMs, raloxifene. Mm-hmm. So it's neat that I've seen all of these things develop, and I've kind of put them in place of therapy.
Mm-hmm. And I really think that's the best way to approach a patient, because I personally believe that dogmas are very dangerous. So if you're saying that medications are the only way, or natural is the only way,
oh, no.
you're really doing a person a disservice, because it should be what's the right way for that person. Like, what are they going through right now? What's going to work best for them? And to really be the kindest and most compassionate to our patients and ourselves, we want to be pulling from all of the resources we can find, not just from, one little bag of tricks that we have.
Oh, I mean, yeah, I'm not married to any therapy. I know bioidentical, but I also know traditional Chinese medicine and acupuncture. And obviously, you and I were both in a tradition of allopathic medicine and nothing that's not FDA approved. So, but I've just seen, that's why you want to have a good practitioner, someone that will give you individual therapy and isn't tied to one therapy.
Yeah, I totally agree with you. And I so appreciate that about you, that you really look at everything that's involved. Now, with respect to symptoms of hormone imbalance, so we know that women with thyroid disease just struggle with a lot of symptoms in general, but how would they know that they need to kind of think about and tune in more to their female hormones?
Well, if it's life modifying, if their hormone symptoms are life modifying, then we have to look into that. I spend a lot of time in my interview trying to, and I have a 12-page, piece of information that I gain from them, and I go through all the symptoms and see if they are hormonal or if not. But yeah, the confusion is stress, thyroid, metabolic issues, thyroid issues, autoimmune, and you have to work through each one of those things. And it always seems like number one thing with women, because they are, and I sympathize with them. My normal patient is either perimenopause or menopause. So they have their parents they're taking care of on one side, their children they're taking care of on the other side. They probably have a job, and then they have a marriage, and then they don't feel well, and it's just incredible. So a lot of it is stress management first, and that hurts your thyroid, and then your hormones. So it's a round and round and round. It's a balance. So
Yeah, it really is. It's kind of I think an important thing is tuning into your own body and figuring out how to listen to it and try to get on the right path, right?
well, and then like as far as the percentages, I mean, the biggest one is vaginal dryness. Then you have sleep issues. We talked about hot flashes and night sweats and libido. And there's time to cure on those. So like as far as like hot flashes, I know that my therapy within 10 to 14 days, if it's not the right therapy, let's assume that we have the adrenal solid and the thyroid solid, and all I'm working with is the bioidentical, or with the hormones. Then 10 to 14 days, if the hot flashes aren't resolved, I know I've got to change the dose. And interestingly, it can be too much hormone, because then you get a refractory receptor. So that's what happens with a lot of obese patients. They haven't balanced out their estrogen because they have so much estrogen coming out of them that they're getting hot flashes. And why would that be? Because they have enough estrogen stored in their, in their adipose tissue. Well, the receptors become refractory. Let's say foggy thinking is huge in women. That can be cured overnight. As a matter of fact, I've had women call me the next day. They put the patch on, and the next day they go, "Oh my God, it was like going blind. I didn't know I was so bad." So
estrogen deficiency, the foggy thinking.
Yeah, estrogen deficiency. Yeah, and there's various symptoms are tied to deficiencies, and I would say libido is one that takes a while That's usually something that once you have all the hormones stabilized, then you see if there's a relationship problem, if there's a body self-image problem, or if it's just, you know, you can lose feeling. And so.
Now, what works for libido in your experience? It's one of those things that's a little bit longer to pick up. Is that?
It's much longer. And again, you know, you have to heal the adrenals and the thyroid. I mean, that's really, really, really. And then you got to look at dyspareunia, which is, you know, like the mechanical, you know, problem. So it's dryness. So usually we use a vaginal estrogen there. Again, I mentioned DHEA. There's actually a DHEA commercial product coming out. It's in stage 3, you know, investigation. So they're going to, and that would be great for cancer patients for vaginal dryness. But we've been making it for about, you know, 20 years. But what I've done, I've also applied testosterone. You have to look at testosterone levels, and not every woman needs testosterone. You really have to find out what your levels are. But if you detect a low level, you can give testosterone. I use topicals better than oral. You can also use it by lozenge, and I've even had it directly on the vagina. That works very well in the right dose.
Mm-hmm.
And there's my favorite therapy of all is, I think I alluded to it, is the vaginal therapy with estrogen and testosterone. It has a lot of success rate. I learned it years ago, and I've seen quite a number of my practitioners use it. And some women say it's messy. You use a 1 ml amount, so it's like 1/5 of a teaspoonful rubbed right on the vaginal tissues. Some feel it's messy and they don't want to do it, but the ones that do it really like it. There's I've used testosterone lozenges under the tongue, just like a Viagra, kind of, and that's been successful. And then there's various creams that I've invented with, you know, many different ingredients like testosterone and niacin, and you know, I think I had amylophenol in there and L-arginine, and
I think you had something that you called Joy Cream, and it was a mixture.
Right, I called it a Joy Cream.
Of different compounds, and that works, and then it's very very low side effects as well, right?
Really nothing except irritation.
Mm-hmm.
So I've used that for many years. I kind of put that together, and it was nothing but I just looked at everything on the market and I said, let's just throw it all together. and it kind of worked, you know. I mean, you know yourself, there's different receptors,
Mm-hmm.
and you just never know what receptor is going to be triggered. It's just like, I mean, we make a number of things. I just sent one of my friends for post-herpetic pain, a topical pain medicine. And that's how we did that one, because there's so many receptors. So we just throw everything into the cream, and it seems to work out.
Yeah, I feel like that kind of pharmacology is such a lost art, and I know you've formulated and created so many amazing products that have helped people over the years.
And I think that was the success of our practice, is that we were inventive, and we found a way to do things. The gentleman that started the compounding practice with me, he liked to tinker with his compounds. So, you know, I would, you know, answer the phones and take the women's questions, and he would tinker with the formulas and get them right, you know. And we'd oh, why don't we try this? Why don't we try that?
And then there's a lot of different mechanisms. So you're looking at increased blood flow and all these other things that can improve the experience, right?
Right. I mean, nerve ending sensitivity, increased blood flow. I mean, there is a commercial product that just came out, Adiye, and unfortunately, and it's an oral tablet you take every day. It's kind of expensive. There's a card that you can get it for $15 or something, but you can't drink alcohol with it. So.
And I went to a pharmacist continuing education meeting this past January, and they were talking about that product, and it was like, they were like, you can't drink with it, and that's fine, not everybody needs to drink, and then you have to take it every day. It's like, okay, and then you've got all these side effects, and then you've got all these issues with it, and come to find, it was like basically you had one more pleasurable experience in like a month or maybe in 2 months. It was like the data behind it was just so limited that I was like, you wouldn't even bother like going through all these different side effects to have this one commercial product, where the products that you developed are just like targeted, and then they work topically and they're not working all over your body to cause so many different
Right. Well, I mean, even commercially, they've gone after that market. Procter & Gamble had a product in the, I think the early 90s, testosterone topically, and they tried to get it on the market. No, this was after the Women's Health Initiative. Now I remember. And they spent a lot of money trying to get it on the market. And it just, for whatever reason, that didn't get on the market. And again, I think women are marginalized, so that when this came up, there's so many Viagra commercials and Cialis commercials. I think they just had to approve this. There are some more in the pipeline. I've seen the research. There's an injection that's going to come through, and a couple others. But I think this had to be rammed through because, women were saying, well, hey, what about us, So, but it, at least we have something on the market.
It's nice to have something at the market, and I appreciate the effort. At the same time, the kind of pharmacology that wakes me up in the morning and that got me through pharmacy school is a lot of the stuff that's like off-label use. So like non-FDA approved uses of medications and compounds, because they're actually the methods of solving problems. So my thing is, my latest hashtag is create cures, not customers. Because when you take a daily pill, you have to keep taking that to support your libido. Whereas with the lifestyle changes and then with the topical creams, you can use that as needed. You don't have to be on it day in and day out.
Right.
So thanks for sharing that experience. Just nice to have a little bit of pharmacist discussion back and forth on all these the politics behind it, as well as the stuff that's out there.
Well, and again, women are just marginalized. I mean, why is so much ad space given to Cialis? And what are these poor women going to do? I mean, to me, that's crazy.
Mm-hmm. Right. And so we talked about hormone imbalances and low libido, and a lot of times these are issues that are from inadequate hormones. But there's also the problem of estrogen dominance, which isn't actually like you can have low hormones and have estrogen dominance, right? So can you talk about the symptoms of that, and then how that all works and ties into women's health?
Yeah, I've seen that in many, many ways. First of all, the symptoms of estrogen dominance, one of the big things is if you can get your rings on and off. That's kind of a bloating thing.
Uh-huh.
Bloating, spotting, bleeding, breast tenderness, things like that. Just think of just before your period. What's that is like, because just before your period is when your progesterone levels dive. The support for the endometrium is not there, so your endometrium starts shedding. And that's a period of estrogen dominance. So a woman would know what their estrogen dominance feels like just before their period. If they're irritable, whatever they see. Breast tenderness is a very big thing. That's, you know, there is a possibility to be estrogen dominant and without having a whole lot of hormones. I mean, I've seen that. The typical blood test I get in postmenopause is low estrogen, but zero progesterone. And that's explained, you know, progesterone comes from ovulation. So you don't get any progesterone, you're going to be estrogen dominant in menopause. And testosterone levels can be up or down also. Testosterone is a metabolite of estrogen. They equalize. Sometimes you can be metabolizing your testosterone to estrogen or the other way around. So you might have a woman that, you know, has facial hair, you know, bloating, irritable, and sometimes the cure to that is just adding some progesterone and balancing it out. And then you try to metabolize or clear out some of the estrogen that is recirculating. And you and I know all about that with the liver and recirculation of toxins. Well, estrogen is a toxin too if it's oxidized and not eliminated, especially the way that a poor quality estrogen is the estrone. That is really the worst estrogen to have in your body because it has more to do with proliferation than the other two estrogens. There's three estrogens: estriol, estradiol, and estrone. And estrone is the one that has the most proliferation possibility. It's the one that can be metabolized the most to proliferative hydroxy. You know, we don't want to go into that products. When the liver processes your estrogen to estrone and it's not gotten rid of, it's recirculated, and it's normally stays in the fat. So you have another you have another organ that's endocrine organ in you as storing the toxins, not only, and we have had that discussion before, but also estrogen, which is actually a toxin at that congener of estrogen. So it's important to balance the estrogens with progesterone, and then make sure they're not recirculating and recognizing. But one thing that I have seen most prominently is with oral contraceptive use and estrogen balance, because many of them are dominant with estrogen, and that can affect the thyroid. And that's one of your hallmarks in your book, getting off of oral contraceptives. That's mainly sometimes with the estrogen dominance in postmenopausal. You're not really threatened with estrogen dominant with any kind of perimenopausal use of estrogen, because it's 10 times less than the oral contraceptives. So it's mostly a supplement. It's not it's not on the order of oral contraceptives.
So women who take oral contraceptives, who are the women at greatest risk for estrogen dominance in your?
I would think so, yeah. And I've seen it, clinically.
Okay. And you mentioned testing. So are there blood tests or saliva tests? What kind of tests do you recommend?
Yes, I've dealt with every kind of test you can get. I normally the doctors that refer to me give me the blood tests. And that's a good starting point. It mainly gives me the relationship of the hormones to each other. The DHEA in the form of DHEAS is a very good test in the blood. Testosterone is, some people, and this is all controversial, testosterone, they actually brought the testosterone testing methods to the women, and it's a man's test for their testosterone. But it seems to be, clinically to me, it seems to be accurate. So DHEA and testosterone are fairly accurate in the blood, and estrogen and progesterone are accurate as far as the mix of the hormones. I also like to see the sex hormone binding globulin, which is the globulin that runs around and binds estrogen and testosterone. And in that, you can find out if, the woman has a lot of estrogen, it's probably, or a lot of testosterone, the globulins are probably up. So if you can release those globulins, you can get a better control. So there's that kind of therapy. And you use some herbs for that, or you switch estrogens for that. That's always a good thing to get a better blood level with something that's already existing than trying to put something back in. Mm-hmm. Then there's saliva testing. I know a lot of people know about saliva testing. There's blood spot testing, which I've used, a combination of saliva and blood spot. And then there's urine testing. I know some practitioners that use urine testing, and the metabolites, I don't have that sophistication for urine testing. And maybe because I don't have that sophistication, I tend not to use it, but I do know I fill prescriptions for practitioners that do very well using urine testing. But I saw a presentation by an expert in our field that seems to show that saliva or saliva and blood spot tracks most of our doses pretty closely. Mm-hmm. The downside of saliva and urine testing is that it's an out-of-pocket expense usually. That's, what can you do? If you want to get good, accurate information, I will use a blood test, and I will, because really the refinement of therapy is with symptom relief. But if I can't get symptom relief, then I will go to a situation where I'll use a saliva test or a saliva blood spot test.
Mm-hmm, mm-hmm. Now, are there labs that you like to use, like brand name labs or?
Yeah, I mean, I'm hooked into all of them. I'm hooked into ZRT labs. I love them. I've used it forever. Genova, I've used them because of the, the GI tests that they have. So, and they're very good with trying to bill for insurance. So, I mean, again, I just use whatever lab that will give me the best information, and then the patient can get the best price from. And I try not to, I stay away from the pricing on that because I want to have people pay me for my service. I don't want to try to sell lab tests. And to me, I don't want to be seen as a practitioner that's pushing lab tests. I only ask for a lab test if I can use it.
Absolutely.
And if I can get by with just using symptoms and not costing a lot of money, I'll try to use the symptoms.
Yeah, I totally agree with you. It's like if it's the results are not going to make a difference, then don't do the test, right?
Right.
The other question I had for you was, with being in the internet age, how do you handle all the information that's out there?
I'm glad you asked that. Yeah, because there's a lot of rumors, a lot of untruths, and it's just incredible. I think what I do is, I try to explain compounding. I was looking at the Endocrine Society. They said that a third to a quarter of the compounding, the hormone therapy now is compounding. And
Wow.
yeah, that's an incredible amount. And they're kind of worried about it because, it's off, it's kind of off their purview because they don't understand compounding and they don't feel that compounding is valid, that the medications aren't FDA approved. And I've heard that so many times, but if you go into a hospital and you need an IV, that's a compound. It's made with 2 FDA approved medications. You put them together and there's commercial IVs, but not many. And the dose is adjusted to the patient. I mean, IVs are prescribed with weight, kidney status, liver status, and even, your race goes into what you prescribe with a IV. So you don't go into these compounding things lightly, and it's the same technology in a compounding pharmacy. It's not taken lightly. And the thing about it is, like you do, some of these diabetics that we deal with, they're compounding. If they're mixing insulins, that's a compound. And it's very common for a diabetic patient to mix insulins together in the same syringe and shoot it. So that's a compound. So, and then the other, so everything is made, a compound is made with FDA approved chemicals put together for a specific patient based on their symptoms and based on your experience and also based on literature. There's a lot of literature that is out there. No, it's not, 500,000 patients, but there's significant amounts of, the N of the study, which would be the amount of people that they studied, are in the hundreds and thousands in some of these things. And then the other thing about compounding is they're not tested for absorption. Well, the major compounding association do testing on the absorption of their hormones. So, I read some of these things. I read everything, and I'm puzzled, by, the statements they're making, and they just don't, they're not doing enough research to make those statements. So,
Oh, go ahead. Oh, thank you so much for sharing that. I just feel like there's a lot of misinformation out there about compounding, and it's, sometimes I get scared because I feel like the big organizations want to take compounding away, and compounding helps so many people.
well, yeah, I mean, right now, you know yourself that we prescribe an antibiotic or, a blood pressure pill, whether you're 50 pounds or 500 pounds. And no, just like IVs, no accommodation for anything. And I try to have enough information for my patients so that they can find the good information and be able to make an informed judgment. And I don't push anything on anyone because I wouldn't, if they're not comfortable with the therapy, I'm not going to push it.
I appreciate that about you. And now, I could really chat with you all day, but I know you've got places to be, and I really appreciate you taking the time to chat with me. So final question is, how do you find a compounding pharmacy, and what should people look for?
Well, you want to find a pharmacy that's in the major organizations. There's two major organizations. Uh, there's Professional Compounding Centers of America, and you can find them at pccarx.com, and you can put in your zip code. The other one is International Academy of Compounding Pharmacists, and that is IACP, and that is iacprx.org. And then there's a further accreditation, and it's pcab.org, and they accredit compounding pharmacies. But just generally, you want to look at the pharmacy. Have they been in business a long time? What's their status in the community? How do the people present themselves? Who do they have on staff? Do they mentor people from the university? Are they active in the community? So, all those things are important to me, finding and probably there's social media would tell you how good the pharmacy is, but I don't know anything about that. So.
Well, Carter, thank you so much for being here with me, and thank you so much for sharing some of your wisdom with us. I really appreciate you taking this time, and I really appreciate the work that you're doing in the world.
Well, thank you. Thank you very much.
Great. And everybody at home, I hope that you enjoyed this and you got as much value from Mr. Carter Black as I did.